My name is Dr. Esther.
Good afternoon, everyone.
Esther Nafula. Yes, welcome to today's session. We are going to start off with a presentation about breaking bad news. And the presentation is going to be by Dr. Maha. She's a palliative care specialist. And she works at Sanand Home Hospice Organization in Beirut. So please welcome Dr. Maha. You can start sharing your screen. We are paying attention to your presentation.
Thank you, Esther. A few minutes. Okay, we start. Hello, everyone. Today we will be talking about how to break bad news to patients and families. Our learning objectives for today from today's session will be outline the component of good communication, apply active listening skills to improve communication with patients and families. Just 1 minute, sorry. Apply spike model to deliver bad news to patients and family members. We'll start with communication. The communication, we will define the communication. Communication is a two-way process between two people or more of giving and receiving messages. Communication exchanges facts, ideas, and even feelings. Much of what we communicate is non-verbal and is communicated through our posture, facial expressions, and gesture. A good communication between health professionals and patients is essential for delivery a high quality of care, and even good communication can influence patients' emotional health, symptom resolution, function, and physiological measures like blood pressure, and to decrease reported pain and drug usage. Good communication with families, it can build trust between the healthcare worker and family. It reduces anxiety, ensure a collaborative process of care, helps to explore concerns both expressed and unexpressed, improves satisfaction with care. The consequences of poor communication, families not receiving important information, significant distress, and decreased confidence and trust in medical care. Patients and families choosing or insisting on ineffective care. Sometimes for children, with when we have poor communication, that may lead the families to become in serious debt, to pay more for treatment that won't be benefit for their child. What is the most important for families in communication with healthcare professionals? We provide them with adequate information, clear and understandable, respond to their concerns, attend to emotions, discuss what can be done, realistic goals, to include them in decision making, and honesty and empathy. To be a good communicator, you must have the knowledge, all the facts that is needed. When you don't know the answer, just tell the family or the patient that you will get back soon with the needed facts. Purpose, you must be clear about the purpose of the discussion, be censored, be empathic. The language, just speak plainly, avoid complex medical terms, be alert to nonverbal clues. We'll move to active listening skills. What is active listening? It's when effort is made to hear more than just the words that another person is sharing. Sometimes with body language, our body language sends a message to another person. The facial expressions can send sometimes an opposite message, such as I'm not interested, or I'm so busy. So let the person speak, interrupt only when there is a need, encourage the person to talk, listen for hidden questions, allow short period of silence, and active listening. Sometimes provide encouraging responses like nodding your head, small responses with yes, I see, or okay. What is bad news? Bad news has been defined as any information likely to alter drastically a patient's view of his or her future, or that result in cognitive, behavioral, or emotional deficit in the person receiving the news that persists for some time after news is received. Breaking bad news, openness and honestly, aim to speak to parents together or the family members, allow plenty of time, involve the family in decision-making. In pediatrics, acknowledge the family as expert in the care of their child. Why it's difficult to break bad news? For physicians, it's just fear of causing pain, being blamed, fear of therapeutic failure, emotional lack of training in communication, and breaking bad news. Most of the physicians, they don't have this training. Lack and language barriers, fear of upsetting the patient's existing family roles or structure. From patients and family perspective, patients often have vivid memory of receiving bad news. Negative experience can have lasting effects on anxiety and depression. We'll move to Spike, the way how to break bad news. The ads will present the settings. Always just remember to invite the important people, the family members that you need to talk with them, get the facts straight, make sure of the convenient time, don't rush, find a quiet room, private place, remember the purpose of the meeting. Always get tissues available for some emotional interference like crying or something. Sit at eye level, minimize interruptions, check in yourself, and just breathe. Perception, always get information from the patient and family before you give information. Ask the questions, what have the doctors told you about your condition? What is your understanding of why you are sick? Invitation, ask for permission to tell more. Can I tell you more about what is happening? Some patients, they don't want to know about their prognosis, so just respect their wish. Ask for preferences. How do you prefer to discuss medical information in your family and family members? And remember the role in healthcare. Doctors will deliver bad news to families. The nurses can elaborate more after the first meeting and give clarifications. The knowledge, give information, give a warning. I have something serious we need to discuss. Give the facts clearly and what the results mean. Use plain language and pause, like your cancer has spread to your liver. It's getting worse despite our treatments. The E, it's empathy and emotions. Allow silence. Listen and observe for any expressions or emotions. Encourage the family members to share how they are feeling. Stop talking when some family members they are crying or have some anger issues. Just stop talking. Allow the expressions of emotions. Sometimes you can use some phrases to make the family feel that you are connected to their emotions, like I wish the situation was different. Sometimes there is a nurse model of empathic response that can be used. N is representing, name the emotions, like I can see you are feeling very angry. The U for understand. I expect most people would feel that way in your situation. R for respect. You have shown remarkable courage. S for support. We will support you through this. And E for explore. Tell me more about how you are feeling. Remember, just use the three W's. It's I wish, I worry, I wonder. I wish allows for aligning with patients or families' hopes. I worry allows for being truthful while sensitive. And I wonder is a subtle way to make recommendations. When family or patients just tell you, I hope I will get better. Remember, I hope that you will get better, but I'm worried that this might not happen based on what we have seen with your condition so far. I'm worried that there is a chance your health may deteriorate quickly, and I wonder if we should talk about that to make sure we plan for how to best care of you and understand what you want in that scenario. And you can use I wonder. If you have more information, you might make different decisions for the time you have left. Sometimes the patient may tell you, I'm hoping for a miracle. So you may answer, I also hope that you will get better, but I'm worried that might not be possible and there is a chance you could get sicker quickly. The S for summary, check overall understanding. Just remember to ask the family members and even the patient, do you have any questions for me? We have talked about a lot of things. Can you tell me what do you understand? And please review the plan for next step. And always remember to document the discussion in the file so the other will know what has been discussed. We'll give you some additional tips. Avoid giving numbers when estimating prognosis. Instead of give an estimated hours to a small number of days, days to a small number of weeks, and weeks to a small number of months. Avoid the phrase, there is nothing more that we can do. Instead, you can use, although there is no cure of this illness, we will continue to support you and your child and manage the pain and other symptoms. The summary, good communication is essential for palliative care. Communication skills can be learned. Active listening and active silence and empathic responses, all of them can be learned and practiced. Spikes is a useful guide to help us to break bad news to families. And remember, the task of breaking bad news, if we do it badly, the patient or family members may never forgive us. But if we do it well, they may never forget us. Thank you.
Thank you, Dr. Maha, for continuing the discussion. I know a few weeks ago we had our session on communication techniques in palliative care, and I think it's so important that we continue to talk about this topic. Dr. Esther, are you with us still?
Yes, I am.
Do you want, now we can go into the larger group time where we allow people to put their questions in the chat or unmute just to talk about this topic. I know we've talked about it quite a bit a few weeks ago, but it's really important. So maybe we can spend the next 20 minutes or so just in a large group discussion talking about this topic of breaking bad news. Does anyone have a question that they would like to ask Dr. Maha? Or we also have Dr. Nafula, who's based in Kenya, and Ruth is a palliative care nurse from the UK, and she's worked many years in East Africa. We have some time for questions.
Hello,
There's
madam.
a question in the chat. Someone would like us to discuss how physicians can become more comfortable with what could be seen as failure of being able to cure the patients.
The easy question
Dr.
to start
Maha?
with. Hey, Dr. Esther. Dr. Maha, do you want to answer that one?
I didn't get that question actually.
Okay. So what is being asked is how can we get physicians to be more comfortable with discussions about treatment failure?
Actually, by practicing and good communication, you can just take that fear from them. And most of the oncologists and cancer patients, let's say, they feel uncomfortable when they need to discuss about the prognosis or breaking bad news. So when they tell the patient or the family about the options of stopping chemotherapy, that will be a failure for them. They can just say it's a failure for them, so they can't stop that treatment. So I think that's the question, or I didn't answer you.
No, that's okay. Rose Gahire, please unmute yourself and ask your question.
Hello, thanks very much for a good presentation. I saw some abbreviation in her presentation about the spike. Is it possible to elaborate more about that spike method? And my second question is to comment on this one also about the physician. Most of the physicians, they don't have time to really listen or communicate well with the patients. Recently, I had my auntie, she had the carcinoma of the valve. But of course, she was treated and then came back in remission. But the way that doctor broke the news to her that it has come back and, you know, because of the wound which was down, they can't do operation or can't do chemo, they can't do radio. The breaking news was very bad to her that it was like she became mad. We had to hold her and she was crying like a baby. So how can we train a physician also, or someone who's going to break the news to know the way how to break it to the patient? Thank you.
Rosa, that's right. What you told us about the oncologist, how they just enter the room, they don't have the plenty of time just to explain everything to the patient and the family. So there is a lot of ways just to learn and practice how to communicate out and how to break bad news to patients and family. And as I mentioned before, sometimes when we do a bad communication, that will will increase the anxiety and may cause the depression for the patients and families. So by practicing and by taking more sessions about how to communicate and how to break bad news, that will make things easier. About your first questions about spike, actually I have mentioned each letter, what does it mean? The S for setting, the P for perception, the I for invitation, just to ask for invitation, the permission from the patient, and to ask from preferences, the knowledge, K for knowledge, to give information, the E for empathy, and S for summary.
Okay, thank you.
Yeah, sometimes, Rose, we use small little acronyms, or that kind of like the poem of different letters when there's several steps to a technique that we don't want to forget a step. So sometimes people write those letters or the words on a piece of paper and they keep it in their pocket so that when they are seeing patients in the clinic or when they're having a home visit or a family meeting, they can easily take out the piece of paper and review it so that they don't forget a step, because all those steps are quite important that Dr. Maha has reviewed with everyone today. So I don't think in medicine and nursing, we expect everyone to memorize all the different steps that we need to remember each day. So we try to use often these kind of shortcuts or special tools to remember. So I think that's why we use the word spikes. It has nothing to do with breaking bad news. It's just an easy way for us to remember the different steps so we don't forget.
Okay, thank you.
Now, there's another question in the chat. Is there a role for the medical social worker during the spike process? And also, could role-playing sessions be of help for feeling confident with breaking bad news? Because demonstration. Dr. Maha, did you hear the questions?
No, actually, I didn't. Sorry, I'm having bad connection, I think.
Oh, sorry. So there's one question about is there any role for the medical social worker during the spike process? And another person has asked about role playing. Would role playing be a good way to instill confidence in breaking bad news?
Okay, the social workers, they may help a lot, especially in empathy and emotions and listening and observing to patients, even when patients, to encourage the family to share how they are feeling. So I think, yes, the social worker may have a great role in breaking bad news. Maybe sometimes when we break the bad news, sometimes we don't involve the social worker a lot in that. Sometimes we just, the physician and the nurse and the family members, we include them in these breaking bad news sessions or communication.
Thank you. Does anyone else have any question?
Dr. Esther, I think Ruth, our nurse from the UK, wanted to comment.
It was just a very general comment to say, I think that doctors and nurses generally are not taught breaking bad skills in breaking bad news and the spike skills. And I think it's something that we all need to ask for more in our training. And I think if you can go back to your workplaces and practice some of these skills that Maha taught us about today, because I think, you know, we can learn these, but actually I think if you can perhaps set up a little group of, say, 3 people, one be the patient, one be the nurse or a doctor or a relative, and have a little scenario and case story and break the bad news, you know then how it feels to have that news broken to you and how difficult. It's very difficult to break bad news. And I think that doing some role play between yourselves and your work colleagues is a really valuable way of learning these skills and taking them forward.
Thank you for that.
I think one other thing I wanted to comment on, as you think of ways to improve your skills, oftentimes when we think of palliative care, sometimes they're soft skills, we call them. So things like empathy and communication. You're not learning formulas or dosages for specific medications, but they are skills that will go a very long way in providing holistic care to your patients. So as Ruth was talking about practicing, maybe now all of you are actually becoming palliative care, what shall we call you? Almost like experts, right? You are learning a new skill that maybe you might be the only one in your workplace that has learned this specific skill. So you are going to eventually become the point person because you've learned some new skills about communication. So you may need to take a leadership role at work in opportunities when you do have the chance for learning and teaching, like at a CME, when you're sitting with your colleagues. You might need to ask your supervisors or those that plan those CME meetings to allow for time to continue to talk about communication and breaking bad news and family meetings and these kinds of things. So now that you've been through, we're on our week 8 of this course, we've talked quite a lot about communication and how important of a role it does play in palliative care. You may need to advocate for more time to learn and practice and teach your other colleagues about these skills. So some of it comes from us. We can continue to share with you the resources, but the next part is you. You have to ask your supervisor for time to practice the role play. And again, we can give you some examples. I know Ruth has a lot of case study examples from her volunteer work in East Africa, where they come up with ideas on how people can practice and speak these things to one another and gain that confidence. But we also are charging you now, as you learn more and more about palliative care, to ask for the time to practice this. We know you're very busy, but again, maybe you can reach out to your CME person that schedules your ongoing education sessions and allow for some time for the communication piece.
I think, Erin, there is a question, does this apply in HIV counseling? Actually, yes, it's just a breaking bad news, even for a waitress who just break her leg. It's to tell her that your leg is broken, you have to sit at home. It's a bad news. For a young mother that she can't have a baby, this is a bad news. So yes, this is applied for any kind of breaking bad news for HIV patients, cardiac patients, for any kind of bad news. So it applies to HIV patients. Yes, sure. It's okay to get emotional while breaking bad news. It's normal. You are a human being. So sometimes, yes, we have feelings. Sometimes as physicians, we cry sometimes when we just break bad news for families or for the patient that there is no cure, there is the prognosis of their disease. Yes, it's fine to get emotional when you break bad news. Yes, it's fine.
Thank you for the answers.
Welcome, Esther.
Yeah, and thank you so much for the good presentation. I think most of us struggle with how to relay bad news to patients and relatives, and most of the time is because we are taught that we need to cure patients. So we also feel like it's a failure on our part. But I think today we've learned a little bit about how to go about breaking bad news and just how to be comfortable to have the difficult discussions. Bang Reef has a question.
Hello. Hello.
Bangbo, please.
Hello.
Hello. Yes.
Yes, are you getting me?
We can hear
Yes,
you.
sorry, our internet is very weak. Our internet is very weak today.
Yes.
Now, since we started, our internet is on and off, so we are not getting you clearly. So for you to spread the bad news, first of all, you should have to be familiar from the patient and from the caretaker, so that they can know you, and can also be in check with them 24/7, so that they can know you and also know the patient. So a new person cannot spread the bad news to a palliative family or a palliative patient whom they don't know each themselves before. Yeah, that is what I can add.
All right, thank you for the comment. Yes. We seem to have lost you.
Maybe they can put their comment in the chat. Their connection is also not good today.
Yeah, we didn't hear that. Then there's a question here. Is hiding bad news from a patient a better way of handling a situation? If the patient opens up on how she can easily take her life when a patient threatens suicide because of bad news. Yeah. How would you handle that situation where a patient maybe threatens to commit suicide because of being given bad news?
Why
Dr.
do you
Maha,
think that she would, why do we think that she will get a suicide from when we tell her about news? When we do it in a correct way and an appropriate way, that well, I don't think that the person or the patient will attempt suicide after that. When we do it in a right way, when we explain everything, we explain the prognosis, the plans of care. So the suicide is not that way to take easily. She can take her life.
Yes. Then I think, yeah, even when we think a patient is going to be suicidal, I think we should assess their mental state first and see which supports they need. Now, another common scenario is where relatives tell us, please do not inform the patient that they are sick or what they're suffering from. And some relatives tell us, if you tell them the bad news, they will die. So how do you respond to a situation like that? Because it's quite common.
Yeah, we have to ensure that families just don't, in our Arab countries, actually, let me just tell you and explain something. A lot of families, they take the responsibilities and the decisions from the patients. So the patient is not having any autonomy or decisions for their treatment or even the code status. The family members, they take that from them. So we have just to ensure the family member just to answer the questions why you don't want us to explain, and just to maybe they had a bad experience of delivering or having a bad news, so maybe because of that they don't want us to tell the truth for the patient. So we have to explain everything for the family members at first, and then sometimes we, in our Arab countries, when the family members, they decide not to tell the truth, sometimes we have to go with the family, and unfortunately, we don't tell the patients the truth. So we have sometimes to respect the culture that we have.
Yes, that sounds, I think that sounds clear. That is clear. Is there any further comments or questions, so we can move on to the case presentation?
Seems like there's a few questions in the chat in regards to healthcare workers' safety when they provide difficult or bad news to families, and there's a risk that the patient or family will hurt them. It sounded like there was one from India, a case, and then again, this last comment from Shem. How will you address a scenario where a family member of the patient acts harshly when you share the difficult news? So I think from my perspective, and I guess Dr. Esther, Dr. Maha, or Ruth, you can also chime in. I think if you get a sense that the family is very stressed about the situation, and it may lead to a very physical or a situation that is risky for you as a healthcare worker, I would advise, and we actually often do advise, not to have these difficult conversations alone. You may want to have your colleagues with you while you share this news. And I think that as a healthcare provider, chances are you are not going to be delivering this difficult news the first time you've ever met the patient or the family. It is really important to ensure that you have a relationship with the patient. Delivering difficult news doesn't happen the first time you meet them. And if it is the first time you meet them, then you probably need to have multiple visits on that day. If it's very urgent that you share the difficult news on the same day, we will most likely want to at first develop some rapport or a trusting relationship with the patient and the family. And I think when you feel that it is a risk that they could hurt you, I would probably suggest that you delay the conversation until there's a point where that risk has been reduced. Because I think as healthcare workers, we don't ever want to put ourselves in a position where something that we are saying or something that we are doing is going to cause someone to hurt us. So I think in a very professional way, if you sense that the family is becoming very aggressive towards you, that you politely suggest that you stop the conversation at the moment because, for such and such a reason, and that you either get your supervisor or someone within your healthcare team that can provide support to you, because I think that it isn't safe. And I think we would never suggest that you put yourself in a position that is like that. It is very, very difficult for families to receive difficult news. And I think sometimes people don't know what to say and don't know how to respond to difficult news. I think a physical reaction is never appropriate from family members, but we understand the amount of stress that they're experiencing, that they sometimes may have an emotion that isn't appropriate. So yeah, I'm not sure, Maha, Dr. Maha, if you have any comments in regards to that, or if it's ever happened in your situations.
No, actually, no. But as you said, it's the best way to do it.
Yeah.
I think
Dr. Esther, has this ever happened to you in Kenya or with your studies?
Sorry, I didn't hear the last bit.
Has it ever happened where someone tried to hurt you when you delivered difficult news?
Okay, we've gotten some aggressive or very angry relatives, and what we often tend to do is to try, when you're going to break bad news, you choose a room that is big enough to give you distance between yourself and the relatives. And again, as you've correctly said, ensure that you are not alone, so that if the relatives are getting angry or physical, at least you have other healthcare providers to shield you. And usually if it gets too heated, we need to give them time to calm down first before we continue with the session at another time. Yeah. It is, although it's rare, but it happens.
Mm-hmm. Ruth, do you have any comments on that? Oh, you're muted, Ruth, sorry.
Sorry. Only to say, I think there's something common in our own humanity, sorry, that we all really want to know what is happening. And I think, sometimes we say, oh, don't tell my mother, don't, it will make her worse or she will die and she can't cope with the news. The patient usually can cope with the news, but it's very difficult for the relatives to hear this. But if you explain very gently, your mother, you know that she's getting weaker, she knows she's refusing food, she can't get out of bed now. She has said to you, I'm sure, that I am getting weaker. And that's the way that you can answer these difficult questions with her, to say, yes, Mum, I can see that you're not getting better, but we're doing what we can to help you. Do you want to ask any other questions? So it's helping them also with the conversations that Breaking Bad News is going to lead on to. And I think that's part of the Breaking Bad News.
Dr. Esther, I can go on to the case now. I think we've answered most of the questions on the chat. There's a lot that are coming in.
All right, we can also keep responding to them as we discuss the case.
Yeah.
The presenter for our case today is Vicky.
Vicky wasn't able to make it, so I'll present on her behalf.
Oh, sorry, yeah, sorry, you're
Sorry.
the one presenting. So yes,
Colin.
Erin, please go ahead and present the case. Erin is a palliative care nurse and she's our course coordinator. I think we are familiar with her. She's currently affiliated to KEHPCA, the Kenya Hospices and Palliative Care Association. Welcome, Erin.
Hi, everyone. So the case that we're going to do today, again, we learn from examples. Just as we are learning from practicing in our workplaces, we can also learn from case studies. So the case we're going to do today, and the main concern for our discussion, is how to communicate with a parent when a child is diagnosed with a condition that is very serious. So this may be very similar to a patient that you see in your clinical setting or that you've heard of. And hopefully we can learn together through this case scenario. So I want to introduce you to our patient for today. She's a 3-month-old baby girl with tetralogy of Fallot. She had a healthy term delivery, yet at age of 1 month, she was admitted to a healthcare facility with pneumonia, which lasted nearly 5 days. She clinically was discharged and she was doing well. Again, at age 3 months, she was presented to an MSF hospital with difficulty breathing. She was irritable and her chest was indrawing. Her saturations had dropped to 79%. It was at this point that a diagnosis of severe bronchospasm was made, and further testing and a point of care ultrasound was done, in which a final diagnosis of tetralogy of Fallot occurred. Her mother was with her at the clinic visit, and her father was at home with their 2 older daughters, aged 18 months and 3 years old. So they have a total of 3 children, all quite very young. The father has employment as a farmer and the mother is a housewife. The family does not have any money for travel or any further treatment. So they are in an economic situation where they aren't able to provide any more funds for her medical treatment. So now, as we think about a palliative care perspective, this is a really severe congenital heart condition that cannot be fixed. This news needs to be provided in a way to the family to show compassion towards them. And that is something that we are learning today, how to break difficult or bad news to patients with palliative care needs. So on the right-hand side, I have a picture here of what tetralogy of Fallot looks like. Sometimes when you are explaining difficult medical terminology or difficult diagnoses, it can be helpful to have images. It may not be helpful. So obviously, you know your patients or your clinical situations, but sometimes it can be helpful to explain. So the biggest concern, especially with focusing on breaking bad news, is the question, how will we tell them the news? We've decided as a medical team, this is her diagnosis. The patient will not be able to be cured. She doesn't have access to surgical repair in the situation where she is. So how are we going to tell them this? How are we going to explain that she is going to be requiring palliative care at this point? So just as Dr. Maha explained earlier, we're going to use the SPIKES model or the acronym for breaking bad news. So again, I would encourage you, if you have a small piece of paper or a small notebook, just even briefly writing out this acronym can help you as you prepare for your family meetings and as you prepare to disclose information to your patients. So we'll go through each step for this case, and then we'll continue to explain more. So in this situation, for this 3-month-old, the family is with us today. We would start by saying, I'm hoping we can discuss what we have learned about your child's sickness, or sorry, why your child is sick and her condition and what we know about it. So we would tell the family that as we are preparing for the meeting, we would make sure that we're in a private room that's quiet. We could invite the counselor or psychologist and even one of the nurses to join us for the meeting. We do need to make sure that we have all the test results and documentation and the patient's chart with us, because patients, well, in this case, the family may have further questions about the situation. So it's really important that you have all the details with you so you can answer accurately in your meeting. So we would then move on to the second step, which is the P, or perception. So we would ask the mother, what is your understanding of why your child, and again, you do want to use the specific name of the child, why your child is sick, so we can better understand what they know about the situation. We could also say, what have the doctors told you about their condition? And then you make sure you allow for time for the caregiver or the family member to speak. So this helps us get a better understanding of what they know. Because if they already know that she's diagnosed with a heart condition that can't be fixed, that will definitely change what we tell them. If they already know some information, that helps us as we break bad news. If they have no idea, then we need to start at the very beginning and we need to share very basic information about their diagnosis. We then move on to the third step, which is invitation. At this point, we ask the parents, in this case, who are the primary caregivers, or if the patient was older, we would ask the patient, can I tell you more? And ask them, can I tell you more about what is happening? So this is where we have, oftentimes in many cultures where you have patients who may not want to know all the information about what is happening, or they would prefer that we talk to their spouse or their adult children about what's going on. Of course, with pediatrics, it's a little bit different. But this is where patients can have the autonomy not to know fully about what's going on, but we still give the patient the autonomy to make that decision. So in this step, we invite, we tell them, or we invite them into the conversation to learn more about what's going on. Can I tell you more about what is happening? If they say no, then you need to identify who the person in the family is going to receive this information. So here we go, on to step 4, knowledge. So this is where we give the information. Dr. Maha was very clear, we need to be concise. We need to make sure the information is simple so they can understand. And this is what you could say. I am very sad to tell you, but I have bad news. That's the warning shot. You often need to give this to your patients because they may not be ready for this kind of news. After you say that, you can pause. So I am very sad to tell you, but I have bad news. And you take a pause. And then you go on and you can say your baby has a very serious problem with her heart. There is a hole inside the heart that should not be there. And the blood vessels that move the blood to the body have not formed properly when the baby was developing inside her mother. This is an example of very clear articulation of the situation, not scientific at all, yet is very clear. Then we can go on and say this problem means that the blood does not flow properly through the heart, and this is causing the problems that your baby is having. Again, we're very clear. We say what the problem is and what this is explaining why the baby is sick. we can continue to go on. The heart needs to work very hard and cannot deliver enough blood to the body because of the problems with the heart. So we continue to say in simple words what's going on. This problem was not caused by anything that the mother did or did not do during her pregnancy. Many times patients are not fully aware of the causes of why illnesses occur or why congenital defects occur or why cancer occurs. And it is very important when we have these discussions that we clarify that it is not something that they did that caused this sickness or this illness. So as we share the knowledge and the information with the patient, it's very important that we are clear and we are concise. We are honest with the patient and the family. Of course, this is a very small patient, so she wouldn't understand, but we are very clear and there doesn't leave a lot of room for miscommunication. It's at this point that you can also allow patients and families to ask questions about their specific diagnosis if they need more information. This is really, really an important time of the discussion. The next step, the fifth step, is the emotion. It is really important as you deliver this difficult news. It is very important, as Dr. Esther and Ruth were saying, that we identify that we are all still very human, that it is still a very emotional time, not only for the family, but also for the healthcare workers. So we try to pause. You can count silently to 10 in your head if it's difficult for you to pause. But we encourage each of you, after you give the difficult information, to pause. And then you could say, I wish the situation was different. And this is a very truthful statement. Many times as healthcare workers, I think all the time as healthcare workers, we don't want our patients to die or to suffer. So I think saying this statement, I wish the situation was different, is very truthful. We also can respond to any emotion that the patient or the caregiver is expressing by saying, I can see that you're very angry. Sometimes caregivers or patients have difficulty expressing their emotions. So as a healthcare worker or someone on the outside, we can help them express their emotion by saying what we think it is. We also acknowledge that many people in their situations would feel the same way. So we can say that. We can say many people would feel this way in your situation. They would feel angry. They would feel very sad. You could also say you have shown remarkable courage, because again, this statement is very true. If you have a mother who has taken their baby to full term, and at 1 and 3 months, the baby was very sick, and now we finally know the final diagnosis, to be going through that journey with this child shows lots of courage for this mother. Then you could say, we are here to help you, and we are here to support you through this. Sometimes it's unsaid or it's acknowledged that the healthcare team is going to support them, but it's very important during these difficult and stressful moments for families that families hear you say that. They might assume that the healthcare workers are going to support them through this, but it's very important that we say it out loud. And during this time, we also want patients and families to tell us more about how they're feeling and how they are experiencing this news. And patients and families or caregivers may not really know what to say. They may be quiet. They may be crying or sad. They may not want to have eye contact with you. These things are all normal when you hear very, very difficult news. Caregivers may be in shock. If the caregiver or the parents are able to tell you how they're feeling, you can encourage them to continue to talk about how they're feeling, but they may not be able to. And as you end the conversation, it's really important as the nurse or the counselor or the medical, the physician, that you summarize what has happened in the discussion thus far. And you allow for any times for any questions to clarify what's going on. When you receive difficult news, a lot of times people have a hard time fully remembering the conversations. So it's important that we do summarize it and answer any further questions they have. Again, a very important part of nursing and in medicine is documenting what you've talked about to the patient. And this is really important so that your other teammates know what has been discussed. And Dr. Esther and Dr. Maha, and as well as Ruth and any other faculty that are on the call, can also confirm that chances are with these difficult conversations, you may have to break bad news several times with the same family regarding the same situation because of the shock that people experience when they receive this kind of information. So as we document that we've had a discussion with the patient, chances are that your other colleagues will also have to do the same thing. It's important at the end of your discussion with patients and families that you make a recommendation for the next step. So you've talked a lot about the situation, the diagnosis, that there may not be a treatment option for their patient, but it is very important that we make a recommendation of what we're going to do next. So what you could say is, based on your child's medical condition or situation and what you shared with us today about what's important for you and your family, I recommend that we make a plan of how we can help you feel comfortable about taking your child home. So in this situation, probably what occurred is the family, with the new information, made a decision that they would like to take their daughter home. So at the end of this discussion, it's really important that we acknowledge that and we help them come up with a plan of how we are going to do that. You may be in a situation where parents or caregivers will say that we were really hoping for a miracle. It's important as healthcare providers that we align ourselves with the parents by using the phrases "I hope" or "I worry." So we are truthful. We also hope that she will get better. This 3-month-old will get better. But I worry that she is not comfortable right now. And there are things that we should do to treat her symptoms. So we also acknowledge and we hope that she's going to do better, but we worry that she's not comfortable. It's really important that we focus on parents and caregivers' strength by saying things like, I can see what a strong force you are for your child, and I support your hope. As doctors, we can help your child in this situation by treating her symptoms and making sure she is comfortable. So we acknowledge that the parent is very strong in this situation, and they are very hopeful as they hope for a miracle. And we, at the same time as we are hoping for a miracle, we know that stop and discharge her. So in this situation, after the parents were made aware of her prognosis, they had difficulty accepting that there were no more treatment options available to cure their daughter. What ended up happening was that multiple counseling sessions occurred with the pediatric team. And in the end, the parents were in acceptance after repeated counseling sessions, and they did request to take the child home. So I think that as we think about this case and this scenario, and as we think about communicating difficult and bad news to patients and families, we need to understand that these situations are ongoing. Chances are you're not going to have just one conversation with a family and they're going to accept it and they're going to they're not going to have any further questions and they're going to feel okay about all that's happening. It will require ongoing counseling sessions and ongoing support. And oftentimes will definitely require ongoing symptom management, which we continue to learn through this course. So I think because we have just a few of us on the call as faculty, Dr. Esther, I think we might continue with a larger group discussion, just as we did after the lecture. If anyone has any further questions about this case or wanted to share a situation when they recently have shared difficult news, so we can all learn from one another. Does that work?
Yes, I think that works well. So anyone with a question or comment, we can start. You can type in the chat or you can raise your hand. So we'll just do the reflection on the case on the larger group.
Mm-hmm.
So there are some comments in the chat that I can go through as we wait for questions. That it's good to you, to explain the terminology, to use images, and the suggestions that we can use. We can also use familiar. We can use parts of other animals that may be more familiar. Then there's a question here: to what extent should we discuss prognosis, especially for cases that are known?
Yeah, so as we talk about prognosis, Dr. Maha addressed it a little bit as we talked about not using very specific days or number of days that we believe a person is going to be alive for, or for how much longer they're going to be alive. So Dr. Maha gave the example of explaining someone might be alive for several hours to days, or several days to months, or weeks to months, or that sort of thing. And I think that is really important. And again, this helps as you have a strong relationship with the family and the patient. So they may be asking about maybe on the side, in the hallway, maybe a family member will come and ask, how much longer do you think my father has to live? And I think when people ask that, you can also ask them a question back. How do you think your father is doing? Or how do you understand what's going on with your father, to kind of get at why they're asking that question. They may be asking the question because they're worried that their father is going to die soon, or their loved one is going to die soon. They may be also curious about maybe there's something they were hoping to do with their loved one before they passed away. I think as people ask questions, it's important to be specific, but also not too specific, because then as things change, you don't necessarily want to say, I think your dad is going to die tonight or tomorrow. This puts a lot of pressure on a prognosis. So I think giving the range of days can be helpful and honest. And I think as we deliver bad news or difficult news, you may not share the prognosis in the first discussion, but maybe at the second or third, or it feels like it's the right time to share that information, then it may be appropriate.
Thank you. Now, there's another question. How do you empathize with the parent's situation, or how do you align yourself with the parent's situation so that you can be able to communicate better with them?
Yeah, if anyone else also wants to comment, you're welcome, any of the other faculty, but I think it's very important in a situation where you need to empathize, you need to not necessarily personalize the situation. If you have also had a loss in your life, it may be not appropriate to share it at the same time, but you want to be truthful about the emotion you're also experiencing as this family experiences bad news. So say, for example, you also had lost a child. You're the nurse in the situation. You also had lost a child within the first year of their life. Truthfully and honestly, you can empathize a lot with this family. They are going through a very difficult time. They're hearing very difficult news, and you want to empathize and align with them. This is not necessarily the time to share about your personal situation, but you share that you also are feeling very emotional about the situation, and you share that you're feeling very sad about the situation, because I think we all do. We all feel very sad for alongside our patients and their families as they receive this difficult information. Yeah, aligning ourselves or empathizing and experiencing the emotions alongside them is very important. We need to be careful as healthcare workers that we don't attach ourselves to specific families, because it's very easy for us to burn out or to cross a boundary, a professional boundary with the family if you do that. But I think sharing a few lines of the emotions that you're also experiencing for the anticipated loss of this child's life or the seriousness of the diagnosis is appropriate. Ruth or Dr. Maha, did you want to share anything about that on how to empathize and align with their situation? Ruth, you just have to unmute. Sorry.
I think it's always best to keep the personal and professional separate, because once you start saying, well, I know what you're going through, this happened to me, then it dilutes their very difficult experience and they have to empathize with you. And I think there's always a borderline there, but I think the general view is that don't mix the two.
I think one thing that Dr. Maha was also mentioning before is the body language. I think we can show a lot of empathy and aligning with the parents and the emotions that they're experiencing, even with our body language. And sometimes we don't have to use words.
The other thing is that if you can set a time and say, look, I've got an hour for this, so that they know that you're not rushing. And they've got time to explore things with you, and perhaps you can have a cup of tea or something at the end, because you're giving them that time. But it does need to be finite. So, maybe at the end of the hour, say, I do need to go now, because you can't go on giving the empathy, and you've got work to do. But giving, limiting the time, but making sure that there's plenty of time is also very important when you set the scene in the setting at the beginning of the spike. These are very difficult, and conversations with parents with sick children is almost more difficult than it is with adults, and their pain is immense.
Yeah, there's also another concern. What about children? When we have children, a child, for example, of 7 years who wishes to know about their diagnosis or prognosis, but the parents are not giving us consent to inform the child about their illness.
Yeah, I think sometimes, and Dr. Esther, you obviously have more clinical experience than I do in a lot of these situations, but I think when we talk to children about their illnesses, Using age-appropriate communication techniques is very, very important. And I think we need to make sure we're on the same page as the family, because of course, a patient and their family, we aren't. So we cannot make a divide between the patient and the family. But I think having informal interactions with children, using play and using drawing and these kinds of techniques to identify what the patient knows, and not doing it separate from the family. Maybe that's at the bedside where we ask very informal questions to help the family understand that maybe the patient knows a little bit, or helping the patient and family understand that the patient wants to know a little bit more about what's going on with their body. These kinds of things can be very helpful. We cannot cause a conflict, especially in these challenging situations where patients are palliative, where they're having a lot of difficulties. I think it takes a lot of work and it's not easy. And it's very important, if there is someone on the healthcare team that the family or the patient seems to really get along with or trust or have a stronger relationship with, then they should try and take the lead on entering into these difficult conversations, because having someone that the patient or the family trusts is really huge as we try to engage in these difficult conversations. So that could be the nurse, it could be the social worker, it could be the primary physician. Dr. Esther, do you have other experience with that, with children that seem to want to know more information, but the family is hesitant?
Well, the important thing is actually to just discuss with the parents and to allay their fears or anxieties and try to find out why they're trying to shield the child from the information. Now, you know, like myself, I work in a public institution, so we have in one room about 15 to 20 children. So sometimes even you might try to shield the child from the information, but they'll still hear it during the rounds. They'll hear it from other children, other parents. So we really try to empower our parents to let us also have sessions and discussions with the children.
Mm-hmm. Mm-hmm. Yeah, I think actually, Dr. Esther, that's a really good point. Oftentimes these discussions, we try and we want to encourage you as much as you can to have these discussions in a private area. But I think we all know the reality is we work in very congested settings, right? Where people are not isolated at the hospital. Maybe we've done a family meeting in an isolated setting, but they're often interacting and talking to other patients and talking about what's going on. So I think we can't, like you're saying, be naive about what people know.
There are some more comments coming. There's a question about applying a distress protocol when we are discussing sensitive topics with patients and they break down. Is this something that can be applied in practice?
Yeah, if Dr. Maha, if you want to comment, I can continue to comment, but you're welcome to jump in. I know that when we have family meetings and we have situations where a patient or a family seems to be at a point where they can no longer have a discussion, you either sense that they are not listening or that they're too emotional, they can't hear what you're sharing, then it is definitely okay to stop the conversation. And you can just be open and honest, and you can say, I have a sense that this conversation is very emotional for you, and that you're not able to hear what I'm saying, and that's okay. And that I recommend that we stop our discussion for now, and I would really like to come back in the afternoon and continue to talk about it. Or I'd like to come back tomorrow and continue with our discussion. I think it is okay to stop having a difficult conversation if you ensure that you set up a time for the next meeting. I think that sometimes people need time to process even a little bit of information, so that when you regather and talk again about the difficult information, maybe they'll be in a different place than they are when they first heard the news. Again, this is the other reason that we have that invitation question, where we invite or we ask people if it's okay that we share the difficult information with them. If they say no, you cannot share the difficult news, because they're telling you very clearly that they don't want to know it. So you need to identify who you can share the news with, especially if clear decisions need to be made, or consent needs to be signed, these kinds of things. You need to identify who is going to make those decisions if the patient is not able to. And again, if it's not the right time, then you ask the patient, when is a better time to have this conversation. You don't avoid the difficult conversation altogether. You reschedule, or you find a better time. There was one other question from Annalise, who had shared, how best can I break bad news of a diagnosis to a husband who just lost his wife 3 weeks ago due to breast cancer, and now has also been diagnosed with extensive psoriasis in diabetes. So this is definitely a reality, especially as we heard last week, related to trauma-informed care or providing care to people who've experienced trauma, which is in many of your cases, many of your patients in humanitarian settings also have experienced trauma. So what do we do? How do we break bad news to patients that are also already grieving or experiencing very, very difficult or traumatic situations? I think this is a really, really important question. I don't know if Dr. Nafula, you wanted to comment or to share how we
I think the first thing here is we need to help him with grief counseling, to deal with the grief first, to deal with the loss. And then, of course, as we continue to manage the psoriasis, then with time, we can explain to him gradually what it means to have psoriasis. Because again, that is a long-term illness together with the diabetes, likely to get complicated. But I think the most urgent thing in that case, in that situation, is the grief. So we deal with the grief first as we manage his illnesses, and then we will deal with breaking the news in stages.
Yeah. Yeah, I think we acknowledge the loss that he's experienced, right, with his wife who just died of cancer. This is very important. And sometimes when we're very busy in our healthcare settings, we don't do that. We don't acknowledge that loss or the trauma that people experience. So before we are able to share any new information, we need to make sure we acknowledge that. I think we have time for a few more questions.
Someone has commented in the chat that he finds it hard to break bad news to family members who are hypertensive or diabetic about their patients with cancer in the last stages. So he wants us to give him some guidance.
Yeah, I mean, I think, and you can definitely correct me if I'm wrong, Dr. Esther, but I think the way we treat hypertension and diabetes has changed so much that these are illnesses, obviously, now that we live with, right? We counsel and we encourage and we treat patients to have a productive and happy life with these very difficult non-communicable diseases of hypertension and diabetes that have a lot of symptoms. And I think that we can acknowledge the difficulty that these patients experience as they have these NCD illnesses. And I think we continue to share difficult news as well with patients with cancer. We know that NCDs are very serious. Someone living with high blood pressure and diabetes can, that can be the cause of their death. And I think sometimes we put cancer on a different level than some of these other diseases, but I think it's very important that we take all of these sort of chronic illnesses very seriously as we share information. We try to explain, we allow lots of times for questions for people to understand. I think just because a patient has been diagnosed with diabetes, they may not fully understand what's going on with their body. So as you're learning more about how to communicate better with your patients, you can also teach them if they have questions about their other illnesses. I think that's definitely appropriate.
I think, yeah, the important thing is about just having even the relatives, if they are stable, it's good to discuss with them. And as we are saying, the breaking of bad news needs to happen gradually. So we look at what information we want to share and we don't burden them with too much information so that they have time to deal with the information that we're giving them.
Shem, just a question. Do you find in your situation that you have patients that come that are very sick and then you identify many illnesses that they didn't know they had? Or others in the group, do you find when you see patients, maybe they're from rural settings or they've had very lack of access or difficulty accessing healthcare facilities? Do you find that you end up having to give diagnoses for many illnesses or multiple comorbidities that patients didn't know that they were dealing with?
Someone says, yeah, that's a good question. What happens when you identify a worse diagnosis than what the patient is presenting with? I think the lesson is just we have to deal with whatever the patient has, whatever else we find, we still have to be able to communicate with them and to be able to support them with the reaction to the bad news. And I think also what helps is also informing patients before we do investigations. Like when we are sending patients for biopsies or scans, it is good to prepare them of what the results might be like. You can tell them these are the kind of results that we expect. It might be this or that, so that when the results come, you now remind them that we discussed when we sent you for the scan, that we were checking maybe if you had metastasis to the liver, and now we found that it is true there's metastasis to the liver. It makes it a bit better than sending patients for multiple investigations and scans. Then when they come back, we don't know where to start explaining to them what we found.
I think we have time for maybe one final comment or question? I know Makulin, you're on the call with us. Did you want to make a final comment from KEHPCA?
Thank you, Erin. Thank you, Erin, Dr. Nafula, and Maha for the presentation today, and to all our participants. I think it's been, indeed, it's been a very enlightening session, and we never get tired of learning. Actually, I've just thought about one of the sessions we had about using images and drawings. I think that's a takeaway, and it's something that we can explore, because body parts are things which everyone, it's standard across many places and people can understand compared to maybe language. So that's a new thing from my side, and I'm sure all of us have learned something new. So just to thank you so much for participating, and we look forward to the next sessions. And thank you, Erin, for coordinating, and all the faculty members for being part of this course. Thank you.
Well, it looks like Shem explained a little bit more about the situation. He said the family members, the mother and father, had comorbidities of hypertension and diabetes, and their daughter was diagnosed with breast cancer. Breaking the news, the mother collapsed and went into a coma for 2 weeks. I think, yeah, I'm very sorry to hear of such a tragic situation. I think that as we share news, of course, we need to understand the situation that we're in. And I would hope that this is a really rare situation where the mother received the information and got very ill. But I think it's just a reminder that when we do share difficult news, it is really, really difficult for our families and their loved ones. And everyone is going to react probably a little bit differently. So I think we need to make sure, yeah, that we're very aware of that. Okay, I think we'll probably end there for today. Thank you everyone so much for all your interesting questions and comments. And thank you again for signing in to the call. Next week, we'll be doing a topic of spirituality in palliative care and how to support people through grief, which is something we touched on a little bit today. So I hope you can join us again. We are getting closer and closer to the end of this course, which is great. And thank you so much for being committed and continuing to learn. So hopefully we'll see you guys next week. Thanks, everyone.
Thank you too. Bye.
Thank you too. Bye.
Bye.
Thank you very much.